Welcome, everyone. It is a pleasure having you with us today. I am Eleni, and I'm a senior product manager at CentoGene. I have been with the company since 2019. I am a biologist and I hold a master's in medical genetics and a PhD in cancer genetics. In this webinar, you will learn more about the benefits and clinical utility of ultra-fast genome sequencing with a focus in the pediatric and neonatal intensive care unit. Genome sequencing is a powerful tool able to detect a variety of variants not previously possible with a single test. Therefore, it has higher diagnostic yield compared to the standard of care. This, coupled with the fast turnaround time of ultra-fast genome sequencing, enables an earlier intervention for the treatment and management of genetic diseases with congenital and neonatal onset. We believe that this approach is here to revolutionize precision medicine approaches in the NICU, and we will tell you all about it. I would now like to introduce our speaker, Professor Peter Bauer. Peter is serving as Chief Medical and Genomic Officer at CentoGene and has been with the company since 2016. Peter is also serving as affiliate professor in the Pomeranian University of Medicine in Stettin in Poland. He is the president of the German Society of Neurogenetics. Peter received his board certification in human genetics in 2006, and he has an extensive experience in high-throughput genetic testing workflows. He has been a pioneer in integrating multi-omic approaches in the routine diagnostic setting. Peter will talk today in more detail about the advantages and utility of ultra-fast genome sequencing in the clinic. Peter will first talk about ultra-fast genome as a new approach in the NICU. I will then share some information about our new service, CentoGenome Ultra-Fast, and then we will go back to Peter, who will share our experience so far with some of the real CentoGenome Ultra-Fast cases from our lab. At the end of the presentation, we will have some time for questions, and please feel free to already use the chat of the webinar to type any questions. Without further ado, Peter, over to you.
Annie, thanks a lot and welcome everybody to this webinar today. I think it's great as well to start off with a product that is very much needed as well, a change for the prognosis, but as well the utility of genome sequencing for children that really need our attention. And so I would like to share with you why we designed this product and what it is integrating. And so being at an emergency unit, it's critical to have answers ideally next day, or at least as soon as possible. Genetics has been seen as a discipline where it takes weeks or months, but here where time matters, we try to stretch something that is super fast and comprehensive. We know that roughly 6% of the newborns need medical attention, and a couple of them really having as well severe conditions that are life-threatening and need right decisions immediately. Here, usually the diagnosis is unclear while the symptoms are very obvious. And with genetic tools, we can help to unlock a diagnosis very rapidly. So I think this combines kind of a diagnostic offer with an opportunity to as well take precision medicine choices later in treatment, but as well in avoiding further harm to a child, small kid that is already critically ill. On the technical level, we learned that the path from single gene testing to panels with sidecars and copy number analysis is all integrated in a comprehensive genome sequencing approach, which now gives us access to single nucleotide variants, indels, copy number variants, structural variants, mitochondrial DNA variants, and as well repeat expansions. So there can't be kind of a more comprehensive test than doing genome sequencing in those children. And now the challenge was to really return as well results as fast as possible. If you compare the standard care pathway, which is having a specialist asking for be it a genetic or another lab test, and then escalate when this comes back negative to ultimately find a diagnosis, you can easily imagine, and that's at the moment really the standard of care, that you lose not only days, but weeks and months until a child is diagnosed. And many of these children sometimes even miss a diagnosis because they pass away in a critical illness before a diagnosis is established. With rapid genome sequencing, on the other side, we have an opportunity to increase the yield over standard of care, but also come back in a very limited amount of days with a suggested diagnosis, and then help the team of specialists at once to discuss a case comprehensively in interdisciplinary teams. There is good evidence that genome fast or ultra-fast genome sequencing in ICU is already very beneficial and has proven clinical utility. And here, time matters, because every day that lapses without a diagnosis not only increases the risk that the child has additional complications or an effective treatment not taken at the earliest possible day, but also in terms of costs. Genome sequencing is reducing the overall cost of these days, and this has been consolidated in a most recent meta-analysis and review of dozens of studies, which you can find here with the link in Genomic in Medicine, authored by Stephen Kingsmore and colleagues from San Diego, the Rady Children's. And so what is the one side is the technical to offer genome sequencing, but the others as well to be as fast as possible, so that all the measures taken from avoiding harm, but as well directing the right treatment, can be focused on this stay for the children that need this support. Now, I think with this framework, we task our teams to come back with a product that includes all these capabilities and also is significantly faster than everything we have offered to our customers before. And so I hand over back to you, Eleni, that you can kind of walk us through the features of these products and how this works in real life.
Thank you, Peter. So yes, I'm very happy to introduce CentoGenome Ultra-Fast today. So CentoGene is next to the physician in critical care or emergency situations, providing CentoGenome Ultra-Fast as the first-line diagnostic test for the earliest possible medical intervention in critical ill patients with genetic disorders. Next, please. The turnaround time of this service is 5 business days. So this test allows the possibility of a rapid diagnosis that can enable the earliest possible medical intervention, and all starting from CentoCard, CentoGene's CE-marked dried blood spot solution as the starting material. And this allows for easier transportation and also sample stability. So this service is available in different options. You have the solo, which is for the index patient. We have the duo for the index patient and also an additional relative, for example, one of the parents or a sibling. And we also have a trio option for the index patient and the parents. And the analysis can be ordered via Cento Portal. Next slide, please. So in this slide, we would like to highlight all the different steps in the sample process that can be done within the 5 business days. So the analysis is ordered via Cento Portal, and the physician can send us the sample using the Cento card. And as soon as we receive the material and we recognize that this is a CentoGenome Ultra-Fast order, this is prioritized end-to-end, all steps of the way. So all the different sample steps: registration, sample preparation, library preparation, sequencing, dry lab pipeline, clinical reporting, and medical interpretation. All the teams prioritize these samples to make sure that we can provide a medical report to the physician within 5 business days, or in some cases even less. Next slide, please. So the CentoGenome Ultra-Fast service is based on Centogene's CentoGenome. So with the 5 business days, we provide the exact same quality in analysis and result interpretation. We are using PCR-free technology for our genome analysis, and this ensures higher uniformity in sequencing coverage, and it can also reduce significantly the bias and provide high quality sequence information for the difficult to sequence genetic regions. So this enables greater insights not only to the coding regions of the genome, but also to regulatory and intronic regions. Our CentoGenome is analyzed by our CIVD bioinformatics pipeline, and our expertise in medical interpretation and also gene curation, which is powered by CentoGene's biodata bank, which at the moment has approximately 750,000 patients. And also to add in the quality, CentoGene provides free of charge confirmation with orthogonal methods for our genome analysis when this is necessary for some variants, and also a variant reclassification report for any variants that are reported and might be reclassified. And here I would like to highlight again what was mentioned earlier, that genome sequencing is a test that can provide the detection of a variety of different variant types, all in one single test. So our analysis includes, apart from the sequence variants, uniparental disomy disorder detection. We can detect uniparental disomy for the known imprinting disorders. Our analysis includes repeat expansion detection for repeat expansion disorders, CNV analysis for spinal muscular atrophy, and also the variants in GBA, the conversion between GBA and its pseudogene, which is associated with Gaucher disease. So with these additional features, we want to show the superiority of genome as the first line test, because it also allows for detection of additionally clinically actionable variants that are associated with human disease. And now I pass over to Peter again, so so that he can talk to us about real clinical cases that we have seen so far.
Yeah, probably. Thanks, Eleni. The most exciting part of this webinar, because it shows really how it works day by day. And we have prepared 4 cases for you in the next 10 minutes that I would like to share with you, which is from these orders of the last weeks and months. The first is a 3-month-old male patient who developed regression early, had EEG abnormalities and seizures, and this was as well the reason for hospitalization with multifocal seizures, which was then diagnosed at the intensive care unit. The family history was unremarkable. There was an unaffected male sibling, and the physician called for an ultra-fast genome because of the aggressive phenotype of these seizures, and of course the notion that the small boy stopped developing normally, and so there was really severe concerns about his prognosis. With the ultra-fast analysis, we identified a hemizygous likely pathogenic variant SLC1682, which affected the coding sequence and created a premature stop codon predicted, which could be linked to an X-linked Allan-Herndon-Dudley syndrome, which is a severe neurological disorder in males with developmental delay, pyramidal signs, and as well this known seizures. Now, technically, it was a very clear call. You can see here in the IGV genome browser that we have super accurate data on this variant with a high quality call. And looking at the consequences of this diagnosis, it helped us to establish a genetic diagnosis in this boy, but also to direct more appropriate and precise anti-epileptic medication. And very importantly as well, open for then carrier testing in the mother especially, and making sure that any additional genetic risk in the family could be addressed in genetic counseling. So a clear diagnosis, and as well not a favorable diagnosis in this boy, but at least a setup after this ultra-fast genome that helped to manage the situation with the family and for the affected child. The second one was a sample from a diseased female patient, and there we also formally didn't see immediately the big need for the fastest genome available, but learning as well about the desperation of the parents and as well their steps taken to reach as well a reproductive decision. We also acknowledged that this also made it very critical in that situation. And so we had a deceased female patient with an abnormal brain morphology, and she died from intracranial hemorrhage with as well seizures and neurodevelopmental abnormality. So the suspicion of the clinician was as well that she suffered from blindness and severe hearing impairment, but this could not be validated due to as well the seizures and due to the hemorrhage she suffered. And so the reason for testing was really to establish the diagnosis and ideally come back with a prognosis for additional children in this couple. After ultra-fast genome analysis, we identified the COL4A1 gene variant, which was a rare missense, but we also could detect a similar case in our biodata bank, which helped to establish a clear diagnosis with a clear classification of this variant, and the related disorder very well matched the phenotype, where we know that COL4A1 diseases are related to small vessel brain disease and a varying severity of ocular and systemic defects. So especially the brain hemorrhage and seizures are very common there and have also been observed in this case. Once again, the technical performance was very good, and this call was established with high quality. We did in the follow-up as well testing of the parents and could establish a de novo mechanism as the most probable one. And so as well the prognosis for now the next steps in their family planning are much helped with this diagnosis. Last case is a 1 year and 10-month-old male patient with a severe condition with coma, encephalopathy, and as well failure to thrive, recurrent infections, polyneuropathy, and as well a need to chronic ventilation, so a tracheostomy was done. In this case as well, family history was unremarkable. Parents are not related. And with additional lab testing done, there was kind of an abnormal finding in the albumin dissociation, and we had some absent brainstem reflexes, probably related to the severe encephalopathy, and of course some skin problems seen from the clinicians. Bickerstaff encephalitis was suspected because the responsiveness to treatment, and this was corticosteroids at the time of the clinical diagnosis, were pretty without any remarkable effect. But then ultra-fast genome sequencing came back with 2 heterozygous variants in the SLC52A3 gene. One of the variants was already seen and classified CentoGene, and the other was a very rare variant of uncertain significance as a missense variant with a potential diagnosis of the Brown-Violletto-Van Leeuwen syndrome, which is a progressive neurological disorder, which presents with kind of as well these cranial nerve neuropathies that we have as well got some information from the clinical picture. Now, 2 heterozygous variants with a parental segregation, which was done in the follow-up, showing them being in trans, explain kind of a biallelic problem in SLC52A3. And interestingly, for this case, after learning about the diagnosis, the application of high-dose corticosteroids were immediately discontinued and kind of phased out, while the appropriate treatment in this condition, which would be a high-dose riboflavin substitution, even helped to stabilize symptoms in this boy. So he responds well in terms of as well supporting the high-dose applications. And taken all together, I think we see that in these cases, really time matters, and as well the comprehensiveness of the approach gives you at least the understanding that everything that can be done genetically is done immediately. So our experience so far is that only just a couple of months into our experience with customers ordering this product, there is very good support, and especially the quick turnaround time makes a difference in as well the clinical actionability. And we see that these patients on the pediatric and neonatal intensive care units, they benefited as well in a couple of cases, like seen in the literature with changed treatment regimens, while all families and parents benefited from faster answers here, and as well having no longer an undiagnosed critically ill child, but children where genetic technology was exhausted. So I think it shows it's not only right after birth, it is relevant as well for smaller children like case 3, and even when there is critical reproductive decisions, we might consider as well going for this ultra-fast test.
We would like to thank you for attending the webinar. I hope you found it interesting and insightful. And so thank you everyone for your attention. And thank you, Peter, very much for sharing all this information with us and talking about the real cases that we have already seen. And so in case additional information is needed, please feel free to contact our customer support team. And also, I would like to let you know that there will be a recording available of this webinar that it will be sent to you, and you will be able to access in case you would like to see it again. Thank you very much.
Yeah, thanks everybody for joining today.